Hey, lovely. One simple question. In a patient who has a GI bleed, would you be more worried if they have anemia or thrombocytopenia? And we have five groups. Um, so Elena, what was the conversation like in your group? What did you all settle on?
Yeah, I'd love to give the mic to everyone because they had like so good thoughts. We were starting with Nicola because he's the hematologist of the group. I found it very interesting how he said that he pays so close attention to the platelet count when somebody is bleeding, and I think it gets red on labs when it's
Yeah.
abnormal. So that's kind of when I pay attention to it, and I think I haven't so far paid attention to it yet intentionally. But I think the argument that the whole group made, Lira included and Muhammad, is that it can sort of predict how well the patient is going to recover from the bleed because it's necessary for like hemostasis, and if you don't have any thrombocytes, the you're probably not going to recover very well from a bleed. And then the second aspect may be that it can tell you something about the severity of the disease, um, because it may imply like other conditions that are around as well, something like cirrhosis, or like bone marrow production issues, or very severe diseases like DIC. And yeah, I think the group is already very knowledgeable about anemia and what how not helpful the hemoglobin is in the acute setting, because usually it doesn't tell you anything about the severity of the bleed, and usually when it gets very low, tells you more something about the chronicity than the severity. Yeah.
That was absolutely beautiful. I will say I bite my tongue and say my reflections until we hear from everybody, but that was yeah, that was really, really wonderful. And the power of four brilliant people combining their minds is unreal. I'm honest with you. I believe you're the only video on representative of your group. So what was the conversation like in your space?
We had an amazing discussion with Dr. Anne and Dr. Koshal, and Iran. So we were thinking in the lines of how, again, Elena mentioned it beautifully. So thrombocytopenia, probably portal hypertension or cirrhosis, and so on. And Dr. Anne mentioned how it's also crucial to see the chronicity and how fast the hemolysis is happening, but probably a normal RBC or a normal hemoglobin might indicate an acute hemolytic state. So even though the patient's bleeding, his hemoglobin might be normal. And yeah, those were the thoughts.
Absolutely superb. Wonderful. Noah, what was it like in your room?
It's kind of very similar to what was said already. I have like a hemoglobin of 14. If I have a really bad GI bleed right now, I could die with a hemoglobin of 14. And then the way of connecting the dots, Hans mentioned, like someone that's so severely thrombocytopenic that any injury to the GI mucosa, they start bleeding, and that's bad news because it's going to be hard to control that bleed, or something causing both the thrombocytopenia and the GI bleed, variceal bleed and cirrhosis being most prominent. And those are always the GI bleeders that end up in the ICU with tons of blood on the floor, and you're like running out of options. So we also vote for thrombocytopenia.
All right, 3 of 3 for thrombocytopenia. Amazing. All right, Jillian, you're up. As the only representative I can see, at least. What did you guys talk about?
Yeah, I feel like everybody said it all, but I
Uh,
guess we started with just sort of thinking like maybe the anemia, if it's a chronic GI bleed, um, or even not, like anemia is not surprising. It would be expected. And so the presence of thrombocytopenia in addition means like either like we have something else to solve, and we did talk about cirrhosis, and also, consumptive coagulopathies that might cause a thrombocytopenia and also might be associated with GI bleeding. So we went for the thrombocytopenia as well.
really, absolutely superb. Excellent. Okay. Alrighty. And oh my gosh, I accidentally recreated the groups because I was thinking a step ahead, but I think Pranay was in the last group. Pranay, any additional thoughts to layer in?
No, kind of similar thought from our group as well. And just one point that Dr. Austin mentioned that we actually connected the dots in the way that thrombocytopenia is more likely to be cause of GI bleeding, whereas anemia is generally a manifestation of GI bleed. In that way, thrombocytopenia is a serious thing if you think about GI bleed, and also the patients that we have seen in the ICU versus floor who have GI bleed, more likely ICU patients have thrombocytopenia, and commonly they are cirrhotic patients. So, yeah.
Beautiful. Alrighty, we're halfway there. You guys picked the thrombocytopenia. And again, I have to just, I won't say anything. But now I have a second question for you all. But um, you have two patients. One has a platelet count of 3, and the other has a platelet count of 30. Same scenario. In a patient with a known GI bleed, who do you worry about more? The patient with a platelet count of 3 or the patient with a platelet count of 30? Another 5-minute breakout room. We will reconvene and nerd out together. All right. See you all soon. All right. Welcome back. So, Siva, what did you guys talk about? What was your vote?
We went with 3
You
just
went
by
for
number base, yeah. And we
oh,
usually like less than 20 we expect bleeding. So
okay. Pawandeep, what was your group?
Yeah, we went similar with 3, but we weren't sure if it's a trick question. Yeah, we went on threshold of numbers, but we also said about having to replace a certain, if you to use one packet of red platelets, would that be sufficient enough in someone who's 30 or 3? And we felt that was more sufficient in one with 3 than it will be in 30.
Love it. Love it. Perfect. Anyone bold and brave and went counter the narrative? Am I being tricky by being tricky, or am I being tricky by not being tricky? All right, let's take a breath.
Rabih, can I ask you something just really quick so I understand the question
Yeah, for
correctly?
sure. I was like, where's that voice coming from? There he is. Hi,
It's Jeff.
Jeffrey. You know, Jeffrey,
Um,
there's a rule that if you're going to talk in the
all
Academy
right,
Center, you have to have your video on,
all right, all right,
which
all
is
right, right.
there. Yes.
All right,
Hi.
I'll have my
How's it
video on.
going?
So, I'm almost thinking like the trick may not be the right word, but I guess one of the mistakes that I realized we not necessarily discussed is this just thrombocytopenia, or is this the dual anemia plus thrombocytopenia? So maybe that could be a different way
Yeah.
of thinking of it.
Yeah.
Because if you have both anemia and thrombocytopenia, then you're in a completely different category of diseases. So I don't know. Maybe that.
It's a really, really good point. The truth that the fun part of these exercises is you don't know, right? Like you're trying to get as much clinical reasoning juice out of possible. So here's what I would propose to you all as like a logical conclusion to what I think the answer is. The truth is, has this been studied in a rigorous randomized controlled trial? The answer is absolutely not. Nobody would do this, but we can get to the thought experiment. So I want to take you to answer a very fundamental question, which is what influences bleeding? So when we say we're worried about a patient with a GI bleed, what we're saying is how much they bleed, right? And I would propose to you that I think in a very simplistic way, there's 2 variables to it. The first is the pressure of the vessel involved, and 2, the coagulation cascade. So not just the coagulation cascade, any factors that participate in thrombogenesis, coagulation cascade, platelets, so on and so forth. Okay, I'm just seeing in the chat that a lot of people are saying 30, and let's see if we can all unite around one answer after. I won't share mine. I will just kind of share the principles. Okay, so Anmol, if you're in a situation where you have a patient who has a bursting AAA, would you rather fix the pressure issue, or would you rather fix any coagulation issues the patient has? If you could only fix one, what do you think you would fix?
That is a very tricky question. I think
let me assist you and ask you a separate question. If you think your patient is having a ruptured AAA, do you think the surgeon will delay the surgery until the thrombocytopenia and coagulation cascade has been corrected? Or do you think she or he will operate right away?
I think that will be operated right away.
Exactly.
That is
So
an emergency.
exactly, right? Your intuition knows it's an emergency. Why is it an emergency? I want you to visualize what's happening. And I think it's unfortunately very morbid. But what's happening is at about initially maybe a pressure of 150 millimeters of mercury is blood gushing out of the aorta. And 150 millimeters of mercury would probably make it halfway across this room. And now it would take the coagulation cascade and the platelet cascade of a giraffe to be able to stop that amount of bleeding. Impossible. And if you imagine that same process on the skin, Anmol, you know how I could fix this process on the skin? Right? Can you imagine trying to stop a bleeding artery on the skin by pumping platelets and coagulation cascade, and all you said you have to do is just this. Pressure, 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 pressure. Pressure is the leading variable in the rate of bleeding. By far and away. If you're lucky enough to entertain the coagulation cascade and platelets as a significant contributor to your bleeding, you've localized the vessel to a low pressure system. So when you're sitting with your surgery colleagues and you see that in their mentality, they don't care so much about the coagulation cascade and platelets, that's not because we're from different universes, it's because we often solve different problems. They're the high pressure bleeders. Pressure, 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 pressure. So you can have an arterial bleed into the GI tract, for sure. And I'll give you two examples. You can have a aneurysm of the aorta erode into the GI tract, often in the duodenum, often in patients who've had prior aortic surgery. It's called an aortoenteric fistula. You can also have a submucosal artery penetrate into the mucosa, causing an arterial bleed, and that's called a Dieulafoy lesion. But absent that, on the arterial side, you actually often have small bleeders, lower pressure bleeders. What is one way that you have a common condition that results in high pressure bleeding? What do you think about that, Lyra? How can you get high pressure bleeding in the GI tract without an aortic enteric fistula or a Dieulafoy lesion?
Yeah, my first thought would be esophageal viruses. I'm not sure if it's so much as a pressure problem as the amount of blood, but potentially also like more pressure problem than coagulation.
Exactly right. Exactly right. When we fix esophageal varices, team, we band them, and we very rarely have to give any coagulation factors and very rarely have to give any platelets. All about the pressures. So when you're trying to ask the question, who do I worry about more with the patient with a GI bleed? You're asking a very simple question. How can I try to figure out, without looking directly in the camera, at what pressure this bleed is presenting? That's your question, right? And you frame it very simply to the question I asked Anmo, which is, imagine it's just on the skin and you're looking at it. You can look at it and you can tell the pressure. Is it gushing or is it oozing? And that's what you're trying to do, but you can't look, right? The GI team needs to look. So you're trying to get proxies for how to look. You all hit the nail on the head with anemia. If the anemia is developing in the context of a GI bleed, it tells you that the pressure is low enough that the body has had time to re-equilibrate. Because in order to get anemia, as Noah so aptly said, you need to have a dilutional component. Because if you lose pure blood and you've only lost at the time of arrival to clinical care pure blood, then when you measure the patient's blood, you still have pure blood. Anemia is a consequence of enough time that the intravascular space has been filled and resuscitated by fluid from the interstitium. So in two patients who are having a GI bleed, you already know they have a GI bleed, the presence of anemia tells you there's been enough time for hemodilution. A patient who's not anemic may not have a GI bleed at all, or may have had a horrifically fast GI bleed that they have not had time to recoil. What is the hemoglobin in a patient with a rupturing AAA? Normal. Baseline. A surgeon is not going to wait for the hemoglobin to operate on a rupturing AAA. So, thrombocytopenia. Why is thrombocytopenia helpful here? To analyze that question, we first have to address the elephant in the room, which actually goes back to a conversation we've had before about platelets and their predictive power of bleeding. In order for platelets to be directly contributing to your bleeding risk, they have to be extremely low. And we're talking single digits here. Single digit thrombocytopenia, when it's super, super low, less than 10 is a very, very narrow differential diagnosis. And that differential diagnosis is really ITP or TTP. Do patients with TTP bleed? Very rarely. They are so thrombogenic, so thrombogenic that their rate of bleeding is actually fairly low. Do patients with ITP bleed? Yes. Do they bleed a lot? Very rarely. I think AMK said it very, very well. So you have your video off, AMK. So I don't know if this is a risky move, but I'm gonna take a 30-second gamble to see if you can explain your thinking out loud, because I think it's just so spot on.
Yeah, I'm sorry I have my video off. I
No, it's okay.
ran a half this morning and I'm
Oh!
still in a state of minor disrepair. So sorry, everyone.
It's all good. Go for it.
Yeah, so I think I really think of platelets as like physiologic vulnerability, and I'm usually more concerned about that intermediate range, because that is where I think of patients with severe portal hypertension lying like the 30 to 50 range. I usually don't see them get below 20. And so that's really what scares me, is it's a physiologic vulnerability saying this patient could have severe portal hypertension. Whereas as Rabih already said, most patients with platelets of 3, it's ITP, and that's usually a minor mucosal bleed. So maybe you're seeing epistaxis that's gone down, or maybe you're seeing something else. But yes, I'm going to transfuse them platelets, but I'm less concerned about them because I don't think that they have a high pressure bleed.
Absolutely superb. Spot on. I couldn't have said it any better. I think when you're approaching a patient with a GI bleed, you're really trying to figure out at what pressure are they bleeding. And your CBC has insight to tell you, both with the hemoglobin and the platelet count, a lot of information. The hemoglobin, if lower, tells you that there has been enough time for reequilibration to occur. The caveat, of course, we must acknowledge, is that the rate of bleeding can change. A patient could have bled before enough to reequilibrate, and now they're here with that same bleed, having rapidly increased the tempo because the peptic ulcer that they had that eroded so slightly into the artery, causing drip, eroded a little bit more, caused a hole. Very, very well described phenomenon. So you have to be careful. You know there's a subacute component to the bleed, but what you don't know is whether it did or did not take off in its tempo. But if you have any insight into the pressure from the platelet count, it's when the platelet count is compatible in a patient with any form of portal hypertension, and that's a platelet count anywhere between 30 to 100. Those are the patients you have to step back and be like, whoa, is this patient have portal hypertension? And the truth is that often your suspicion of portal hypertension is cemented by seeing a platelet count, because you see so much evidence of portal hypertension everywhere else, that if this reflection is news to you, it's because you're applying the base rate. Portal hypertension is not a diagnosis based on just platelet count. It's based on so many other features. Cirrhosis, caput medusae, ascites, so on and so forth. But just to rewind the clock and play yesterday's case and listen to it one more time to see how sometimes the platelet count alone is your only reasonable clue for portal hypertension. And if you wanted yet another reminder, you should check out the case that Pranay presented on Tuesday VMR to Dr. Ravi a long, long time ago. That will make you humble yet again. So for me, when I see a platelet count like that, as Amke just said, PPI, octreotide, and this is the patient I would call GI right away. So what are the big takeaways here? I don't know why I said big 7 times there. Is bleeding is sometimes influenced by coagulation factors and platelets, but that is a microscopically small variable compared to the pressure. If you have anything that gives you insight into higher pressure artery or high pressure venous bleeds, that variable will supersede any other variable. Questions, reflections? Anyone? Yeah, I'll turn the video off.